Welcome, everybody. This is the Employers Forum of Indiana meeting. It's our first annual meeting, or not annual meeting, I'm sorry, it's our first all stakeholder meeting of the year. I hope all of you are doing well. Many of you have probably already received your vaccine, and congratulations. I am looking forward to getting mine. This is by Zoom. Our May 6th all stakeholder meeting will be by Zoom as well, but we hope the subsequent ones beginning in August, September will all be in person. So our September one, I just want to say this up front, we are looking forward to having an all-day session in September, followed by a cocktail hour. We just want to build in a lot of networking opportunities since we all haven't had a chance to see each other in such a long time. But thank you for being here. We have a really robust agenda, so I'm just going to jump right into it. So we'll be talking about addressing high hospital prices, and this says part one because the May 6th will also be regarding pharmacy. Next slide. So I will tee up the topic. Next slide. We have Troy Trigestad here. So Troy is a dear friend of mine who I've known, I think, 20 years. Troy's a community pharmacist, a health economist, and a pharmacy visionary who continues to encourage pharmacy industry leaders into new and innovative ways of thinking. He is the executive director of CPESN, which he will discuss during his presentation, a clinically integrated network of community-based pharmacy networks that endeavors to improve the quality and effectiveness of enhanced services provided by participating pharmacies and align them with workflows and payment reforms with physicians and their support staff. He also serves as Vice President of Pharmacy Provider Partnerships for Community Care of North Carolina. And this organization provides a wraparound service for population health to support nearly 2,000 primary care practices. He has presented at the forum before many years ago, and we are happy to welcome him back. Troy has served as a consultant to IU Bloomington and other organizations in our state. He's not only just a PharmD, so he has his doctorate in pharmacy, he's also an MBA and has his PhD. So he's my smartest friend with the most terminal degrees. I'm going to go ahead and, next slide. Sarah, there you go. Next, we'll have Candace Schaefer presenting, and Candace is Senior Director of Benefits at Purdue University. In this role, Candace manages the strategic planning and customer service of a strong benefits plan for the employees and their families. This includes medical and dental benefits, as well as retirement, leave, worker compensation, families, and the systems and processes in place to help employees engage with those programs. Candace is going to be presenting to us on specialty pharmacy and what Purdue's doing uniquely in this space, and then we'll be moderating our open discussion. Next, we will have Ed Isaacson. Ed is, since 1992, Ed Isaacson has been the Human Resources Director of the Roman Catholic Archdiocese of Indianapolis. Among other responsibilities, he is responsible for developing strategies for recruitment and retention, compensation, and benefits. He will be discussing maximizing copay assistance in GoodRx. He's co-presenting with Amy Ball, who also is a PharmD. And I would like to say that, Ed has been an innovative employer who I've reached out to many times, and he's really focused on aligning payment with quality, and I think you'll enjoy his presentation. He brought in a consultant, Amy Ball, and Amy's co-presenting with him. She is Chief Pharmacy Officer responsible for the development of clinical strategy for an organization called Health Strategy. She provides consultative services for large self-funded employers and other healthcare payers to maximize the value of their pharmacy benefits. I first heard of Amy years ago during a presentation at the Midwest Business Group on health, where Caterpillar was presenting, and they had brought her on to do a cost plus contract with Walgreens. So basically whatever the cost was at Walgreens, they just had an add-on fee instead of going through kind of the more traditional pathway with PBMs and payment. And she is a Boilermaker, so graduated from Purdue College of Pharmacy. As many of you know, I have strong connections to that university as well. Rich Musti will present next, and Rich is the president and co-owner of Unified Group Services, a privately held TPA for self-funded group health plans. He's been working with employers on innovative and flexible ways since 2004. What I really appreciate about Rich, Mark, and Daniel is they are smaller, more nimble, and innovative, and they have done some really unique things that they'll be sharing with us during this presentation. So Mark Williams is a fourth-generation pharmacist with nearly 30 years of retail pharmacy experience. With his two brothers, he owns and operates Williams Brothers Healthcare Pharmacy, a chain of independent pharmacies with more than 500 employees, so a big independent pharmacy. As a business owner, he realized the downfalls of many PBMs and developed a passion for providing true, transparent PBM partnerships. So he also has a PBM, and he's another Boilermaker. Daniel Wilson will be co-presenting with them after earning his doctorate of pharmacy also at Purdue University. And I did not do this. There are no Butler College of Pharmacy graduates on this panel, but they will be on the May 6th one. Daniel completed his residency at Indiana University Health at Bloomington and became a board certified pharmacotherapy specialist. He also holds a pharmacogenomics certificate from the American Society of Health System Pharmacists. He is Director of Clinical Programs at TrueRx Health Strategist. So he's our third Boilermaker. And I do believe Daniel was probably one of my students because he doesn't look that old. Sherry Alexander will be presenting our next presentation along with Jeff Post. Many of you know Sherry. She's works at Gregory and Appel. Sherry has spent 15 years building and leading employee benefits, the benefits department at Gregory and Appel, and now she serves as their Chief Strategy Officer. Sherry has decades of experience in the employee benefits world. And, she not only understands the complexities of healthcare and all the stakeholders and how they interact, she really has a deep understanding and someone that I go to often about how we're going to fix our healthcare issues that we have and thinks outside the box. So I'm really happy that she's able to present with us along with Jeff Post. So Jeff Post is a Chief Clinical Officer for RX Connection. He has presented at the forum a couple of times before on our dumb drugs and other presentations. In his role, he serves as he is a Chief Clinical Officer at RX Connection, and in this role of executive sponsor and strategy leads for key clients. Jeff oversees the clinical risk management program, which includes clinical diagnostic reporting, plan education, PBM customer programming, clinical auditing, and plan sponsor decision support. So what's really unique about Jeff is he helps dive into the PBM contracts and provides recommendations to clients, as does Amy. So he is from, he got his pharmacy degree from Ohio Northern University. We won't hold that against him, and welcome everybody today. We will end with a panel discussion. We have plenty of time for questions. Each of these presenters are going to present for about 20 minutes just to present some high-level information to you regarding what they're doing that's unique and innovative in the space of pharmacy to control healthcare costs and improve quality. We welcome questions after each presentation if you want to put them in the chat box. If you want to ask your question verbally, because this is Zoom webinar, we can unmute each person. I believe we can unmute each person. If you just put in the chat box, unmute me if you want to ask your question live, or you can just type your question. Candace will, we will take questions if there's time at the end of each presentation, maybe just one or two questions, again, if there's time. If not, we'll have all of our questions addressed during the panel discussion, and we have about an hour set aside for that. So please feel free to type your questions as you think of them, and Candace will be moderating that. So to tee us off, I'm just going to set the stage here with some stats. So US healthcare spend is on the rise. We all know that. It increased in 2019 by 4.6%. Retail prescription drug spending accounted for 10% of total healthcare spending. It used to be 3%, 5%, 8%. Last year, or 18, it was 9%, and now it's 10%. So as many employers understand, while it's not the largest cost, not the largest slice of our cost pie, it is the fastest growing slice. Of course, the largest is hospital services. We've spent quite a bit of time over the years discussing that. Physicians, and they represent about 45%, give or take, of employer costs. Physician services represent about 25%, and again, pharmacy services about 10%. So retail prescription drug spending was higher than just the average healthcare spend at 5.7%. And as we all know, the burden to employees and covered lives just keeps increasing at a faster rate than salaries and inflation. Next slide, please. I want to spend some time on this slide too. This comes from the Healthcare Cost Institute, and it's from their 2018 report. And it looks at cumulative change in spend per person, looking at utilization, so per person spend, utilization, and average price by service category. So if you look at the first graph, you can see that prescription drugs, just since 2014, over a 5-year period, has really increased significantly in price. And it's gone up, as we said, about 4.3% in utilization, but 20.6% in price. So that both of those, of course, impact our cost or our spending, which has skyrocketed. So this is why it's important at the forum that while we are spending quite a bit of time looking at inpatient and outpatient opportunities, professional services, that we also look at how we can optimize prescription drug spending. Next slide, please. So you guys have seen many complex slides at past forum meetings. This is a really simple slide. I like it, and maybe it's helpful to you as you present the information to your C-suite on the flow of drug distribution. So the pharmacy benefit manager is there in the red, and they really are the one that has the most touch points. You can see that they have connections to the insurers, they have connections to the drug manufacturers, and they have connections to the pharmacies. And because they sit at the center, there's a lot of controversy around it because they don't have, most of them traditionally don't have a lot of transparency around the rebates that they're getting from the drug manufacturers, how they're passing the rebates on to insurers, the negotiations that they have with the pharmacies, and so they are a point of focus, as I'll talk about here in just a minute. And I would say a point of opportunity as well, and you'll hear from some more innovative strategies that some of the PBMs are engaging in. Next slide, please. We hear a lot about prescription drug coupons. Here's the traditional model, and I bring this up because some of the presenters are going to be talking about how to optimize drug coupons. But traditionally, a manufacturer, and the coupon is there in the C with step 1, they have a drug coupon, right? And the patient may download this from their website. They may find it at the physician's office. That coupon gives the patient, in this example, a $300 coupon, and they have to pay cash for $310 for this particular prescription. So there's a patient giving the pharmacy the coupon, giving them their cash, and the pharmacy is giving them their medications in blue. Kind of following the arrows, you see that the pharmacy reports to the plan that the patient paid $610, but they actually only paid $310. And the plan is recording $610 in patient out-of-pocket spending, where if they're in a high deductible health plan, they didn't really pay $610, they only paid $300. But some plans have now figured out how to capture that, and we'll hear more about it shortly. Next slide, please. So one of the many problems within our pharmacy space is medication non-adherence. And I would expand that to say it's not just non-adherence, but that's the measure we can look at. What we really want to do is make sure that patients get the right drug at the right dose, and so that they're improving their therapeutic outcomes. We look at medication adherence because we can measure it, and it's a intermediate measure, if you will. But here's what we know about medication non-adherence. 9%, and I mention this is because someone could be non-adherent to the way their prescription is written, but let's say it's a cholesterol medication, but their LDL, their cholesterol lab values are at goal. So even though it looks like they're non-adherent, maybe they're taking it every other day for a variety of reasons, they're therapeutically at goal. So we shouldn't be pushing medication adherence without making sure that we're keeping an eye on therapeutics. Same goes for diabetes and anti-coag and really all medications. But 9% of all new prescription starts were abandoned at retail pharmacies in 2019. And we want to explore that a little bit. So prescriptions are being written, 9% are being abandoned, meaning that they never come and pick them up. Prescription abandonment rates are less than 5% if there's no out-of-pocket expense. Of course, with your drug benefit design, you can say if they're going to tier 1, they don't have any out-of-pocket, or maybe for certain select drugs that you consider to be preventative, there's no out-of-pocket. But the non-adherence rate goes up to 45% when there's a cost over $125 and 60% when it's over $500. The average abandonment rate of diabetes, anti-coags, oral cancer medications is 18% of all new therapy starts. And that is just astonishing to me, because these three conditions lead to high admissions, ED visits, urgent care visits, but really admissions is in readmissions. Next slide, please. Here's just a chart that looks at prescription non-adherence as it relates to price. I mentioned some of the stats earlier, but thought you may be interested in looking at the resource. Next slide. So we talked, gosh, I think it's been over a year ago now, about GoodRx and some of these discount cards. And the question came up, well, how do they work? You know, and I didn't really fully understand how they work. So I want to thank our intern, Delaram Hajoti, who looked into this. She contacted pharmacies and PBMs and these different vendors. And I have one slide to essentially say that there are many different discount cards. GoodRx is just one of them, that there's Blink Health and ScriptSave. They typically can't be used with insurance, but do serve as an additional option for patients. But some PBMs have figured out how to incorporate these discount cards, and we'll hear more about that. So one might ask, you know, I have insurance. I have a prescription drug card. Why is it that I can download the GoodRx app on my phone and get the medications at half the price or a substantially discounted rate, sometimes 80% off, than my price that I get from my PBM, you know, that I'm paying for? And the reason is that some of these companies, they don't just contract with one PBM, they contract with a bunch of PBMs. So you're getting the benefit, or the people who are using GoodRx and these other services are getting the benefit of not just having one PBM's rates, but you know, over a dozen PBM rates. And that's how you can search for it. So if any of you don't have the GoodRx app, I use it all the time for my mom and other family members. It's easy, and then these others are, I'm not as familiar with them, but I've heard good things about them as well. Next slide, please. So there's, you know, lots of innovation happening in this space. I thought this was interesting, something that you might be interested in. Mark Cuban, who many of you know from Shark Tank, he's developed a cost plus drug company, and there's the website for it. And he really is going to be, he says he'll be fully transparent in what the drug cost is, the manufacturing price, and then he's going to add a flat, 15% profit margin onto it. The first drug that they have available is written there for you, albendazole, and that's an anti-parasitic drug. So for hookworm and all these different worms that can get into your bloodstream. The average cash price for this drug per tablet is $225. He's going to make this drug, he says, to make it and distribute it will cost $13, adding his 15% margin on it makes the charge of the drug $15 per tablet. And that'll be available that's their wholesale price to pharmacies, clinics, hospitals, and then they're recommending manufacturer suggested MSRP of $20. So he plans to have a you know, over a dozen drugs available by year's end. He says 100, but we'll see. It's just something to keep an eye on. I really think this cost plus is an interesting idea and just puts more transparency into the, you know, into the chaos. Next slide, please. So there also are a lot of legislative solutions. There was a recent Supreme Court ruling that said that PBMs can be regulated at the state level. That's a summary of it. And so there are, oops, let's see. So you guys didn't see that pop up. There's a lot of legislation happening in numerous states, including our state. So 36 states have passed or are actively advancing legislation in 4 different areas: in transparency, copay caps, insulin caps, and anti-price gouging. And there's some information there for you if you're interested in the space. Next slide, please. In Indiana, currently we are in our legislative session, as many of you know. We had several bills. We have several bills that are looking at PBM legislation. So Senate Bill 62 died earlier this week. Senate Bill 131 and Senate Bill 62 had to do with requiring rebates to be provided to patients at the point of sale counter, so at the pharmacy, that the rebates that are given to the PBMs by the manufacturers, 85% of that had to go to the patient at the point of sale. That died, but my understanding is that there's just too many bills and the legislators want to consolidate these bills. So that language may come back up. We are now starting, so right now, the House, all the bills that passed the House and all the bills that passed the Senate have gone through. And starting tomorrow, they will be switching houses and get different assignments to various committees. And then they'll start back up on Monday in their opposite houses. So Senate Bill 131 and 143 are alive. They are passing the Senate and going to the House. And the House Bill 1393 is also alive and will be going to the Senate. They change almost, it seems like every other day. Lots of amendments are being offered to all of these bills. Sometimes they just gut the entire bill. Sometimes they have, you know, there'll be 6 or 7 new amendments added. So in the interest of time, if you're interested in this topic, I would recommend that you go to iga.in.gov, go to this website, and then there's a section that calls, there's a tab that says bills, and you can just put one of these bill numbers in there, hit latest version, and you'll be able to see it. But you'll also be able to see the initial version and all the amendments when it's going to be heard in committee. If you have any thoughts on this, I'd recommend that you talk to the legislators or the committee members that these bills are being assigned to, or you're welcome to talk to me as well.